Matt, what sound does a nut make when it sneezes?
I don't know, Paul.
Cashew.
All right, I'm not gonna give you my sneeze pun then, which was in a similar vein. Paul,
I didn't mean to poach. I'm sorry.
What bacon makes you sneeze?
I don't know, Matt. What bacon does make you sneeze?
Peppa Pig.
Oh, because pepper makes you sneeze.
Yeah, I think so.
Okay. All right. Last one for me, Matt. What do you give a sneezing snake?
I can't even think. I don't know.
It's getting late, folks. That would be an antihistamine.
Okay, that's a good one. We'll bring it into the episode with that.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like More Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, maybe even the primary care physician, Dr. Paul Nelson Williams. Hey, Paul.
Hi, Matt. How are you?
I'm doing well. We have a returning guest, Dr. Olajumoke Fadugba, talking about seasonal allergies. She last talked to us about anaphylaxis, and that was 5 years ago, Paul, because we have been doing this show for a long time, and we are getting old.
Yeah, getting. Yeah, I think that ship has sailed for me, at least.
So, Paul, we had with us a great off-air producer, Dr. Leah Witt, who unfortunately could not join us on air, but we are so grateful for all her great work on this episode. And before we tell the audience about our wonderful guest, Paul, what is it that we do on Curbsiders?
Sure, Matt. As a reminder to our audience, we are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. Matt, would you like me to tell you about our guest?
Yeah, Paul, that would be lovely.
All right. Well, we're joined by Dr. Olajumoke Fadugba, who is an associate professor of clinical medicine at the Perelman School of Medicine at the University of Pennsylvania, where she serves as the chief of allergy and immunology and as the program director of the Allergy and Immunology Fellowship Program. Dr. Fadugba attended the Imperial College of Science, Technology, and Medicine in London, which is the coolest name of, I think, any higher learning institution I've ever heard, as well as the University of Delaware, where she received her Bachelor of Science in Biochemistry. She received her medical degree from Vanderbilt University School of Medicine, completed her internship and residency at the internal medicine at Barnes-Jewish Hospital at Washington University, and returned to complete her allergy and immunology fellowship at Vanderbilt. Dr. Fadugba's areas of clinical focus are drug allergy, mast cell disorders, and anaphylaxis. Her research is focused on the impact of beta-lactam allergy in cancer patients, and she leads innovative antibiotic allergy delabeling interventions in special populations such as those with cancer and pregnant women, while exploring practical and psychosocial barriers to these efforts. In this episode, we hear all about primarily allergic rhinitis and her approach to management thereof, but also we talked a lot about non-allergic rhinitis in terms of like some of the oddballs like gustatory and vasomotor. So apparently not all rhinitis, Matt, is allergic, which was exciting to find out. And now we'll be better equipped to manage that. So without further ado, let's get to our episode.
A reminder that this and most episodes are available for CME for all health professionals through VCU Health at curbsiders.vcuhealth.org. And also, if you haven't yet done so, please join our Patreon at patreon.com/curbsiders, where you can get ad-free episodes, twice monthly bonus episodes, access to our private Discord server, a whole bunch of other cool stuff. Check it out at patreon.com/curbsiders. Jumi, so nice of you to join us again. We were just talking about 5 years since you've been on the show. So maybe you've picked up some new hobbies or interests outside of medicine, but the audience, they would love to hear what those are.
Matt, nice to see you again. I think my hobbies haven't really changed. It's still, kids and whatever their hobbies are. I do still like to read, and I'm still doing a pretty good job. I think probably even better than the last time we spoke, and keeping up with my reading. And so, yeah, it's a nice escape.
And for the audience, Paul did not record with Jumi last time because we were at ACP and we had so much going on that Paul was doing one recording at the same time I was doing another one. So this is the first time you're meeting. So Paul, you must want to be asking her something.
Well, sure. I'll ask the standard, which is also a favorite. We love to hear any advice or feedback, either that you like to give or that you receive that was especially meaningful to you. And it doesn't even have to necessarily be medicine related.
I thought about giving a medicine related one, but I think one that's pretty good for life, and I do apply it in my work and in my role as a leader. And that is the idea of talking to people directly when you have issues or problems, if and when possible, finding ways to address even conflict or potential conflict with the person directly. There are many other ways of handling that, and I have found that sort of taking the brave, very sometimes difficult route takes practice, but doing it even when you're not a leader, I think is a great way to sort of build good relationships and, maintain trust and integrity. And I've just found that over and over. I don't always do it perfectly, but I think that's a good piece of advice in general.
For sure. Especially since I think so many of us in medicine are conflict avoidant
Yeah,
just by our very
for
nature. And
sure.
it's so instead you internalize and agonize and,
Yeah.
catastrophize. And it's just so much simpler sometimes to address things head on and so much more of a relief if you do it well. So that's great advice.
I was thinking about this the other day because I was talking to a colleague about how when Paul and I were in residency, there were paper charts and everyone would have to be at the nurse's station writing in the charts. So you knew all your consultants, you talked with them face to face
Yeah.
on the regular. And I
Mhm.
think we've lost that. And then when you're just
Yeah.
kind of texting back and forth or
Yeah.
messaging back and forth, it's hard to understand tone. So
Oh, yeah.
talking face to face is preferred. You usually get a much different response. Or
Totally.
talking by phone, I feel like people are usually less likely to be rude than they are. It's easier to be rude on text
Oh,
message
yeah.
or dismissive. So
Yeah.
that's one way techechnology is ruining us,
I
Paul. Don't you
agree.
agree?
But I don't know if this we need to include this in the episode, but there was a cardiothoracic surgeon, still is, where I had previously worked, and we were working together on a patient who was having recurrent pleural effusions, and I really could not understand why we were going for another thoracentesis. I could not understand the point. So I text paged this person, and much to their credit, they're like, I will be on the floor in 5 minutes. And they came up in 4 minutes, apologized for running late, and then
Yeah.
very thoughtfully and directly explained to me what the rationale was. And it was just so lovely to have this face to face
Oh my
conversation. And it was
gosh.
not confrontational. And like at the end of it, I felt better now. She's someone that I refer
Totally.
to frequently and get along with wonderfully just because we sort of direct the situation head
Yeah.
on rather than passively aggressively
That
discussing ducks in the progress
and the
notes. It was
and the
wonderful.
efficiency of it, right? Like
Yeah.
all those back
Very
and forth
surgery.
and yeah, just do it. There's a lot you get through and you don't have to do the back and forth text. And yeah, I agree. Picking up the phone or talking to the person in person is a great way to go. Mm.
We are glad to have you here as our consultant, and I'm sure that you always give great consults and are never rude by text or message. So Paul, let's give her a consult. Let's read a case from Cash Flack and let's get into the main topic.
Yeah, so we're going to talk about Clara. Clara is a 36-year-old woman. She's coming to our office, well, to your clinic, actually, for bothersome seasonal allergy symptoms. Every spring, when the trees and the flowers begin to bloom, she notices watery and itchy eyes. She has a runny nose and a chronic cough that's bothersome. She has tried taking diphenhydramine, but it's helpful, but she has side effects of mouth dryness and she feels a little bit sleepy with it. She works remotely from home, and even though she's indoors a lot of the time, she's still having a fair amount of symptoms with this. She can barely get through her Zoom meetings at her job without sneezing or sniffling. She has pretty significant fatigue, and she had to take a day off of work last week. So this has become disruptive to the point where we have now referred her to come see you. So she reports to you a childhood history of asthma, and every winter she develops eczema. So we're painting a picture of A to B here. So for you, when you're seeing this sort of prototypical patient with seasonal allergies in the office, I would love to hear sort of what your first office visit looks like and how you start with the patients reporting symptoms like this.
Yeah. Well, like with any clinical situation, the history is key. We will elicit much of what you've already described from the patient, but we will focus a lot on the pattern. So, for example, is it perennial, i.e., year round, or is it seasonal? We ask about triggers. So, I can list some of them. So, they include, is it worse in spring, summer, fall? That's seasonal, right? Is it worse with weather change? Is it worse with strong fragrances or smells or fumes? Do you have any, we asked about exposures. So do you have a pet? Do you have carpeting? That sort of gets at dust mites potentially. Do you have visible mold? And we do stress visible mold because many people suspect they have mold in their homes for various reasons, including a musty smelling basement. That doesn't mean that it's causing symptoms. And then we go a little bit deeper into the nature of the symptoms because sometimes you can predict whether or not this is going to be allergic versus non-allergic rhinitis based on the nature of the symptoms. You've already kind of highlighted some of them, but I do ask very specifically about if the patient doesn't volunteer it, is there sneezing or not, itching or not? Is there a predominance of sinus pressure and pain, which sort of gets at perhaps a chronic sinusitis, which can overlap with rhinitis? And is there hyposmia or reduced sense of smell? Those types of things can be helpful. They not only help predict whether or not it's allergies or what the allergies are, but also what treatments they're likely to need for their symptoms.
I just want to clarify some of what you said there with someone with sensitivity to fragrances, smells, fumes, pets, carpets, is that more of the perennial rhinitis that would make you think that?
Well, so what I'm getting at in a way is so somebody who has things like season change, strong fragrances and fumes, temperature change as a main trigger is more likely to have what we call vasomotor rhinitis, not which is the most common type of non-allergic rhinitis. And so I'll ask those questions for that reason. Of course, some patients have both allergic and vasomotor rhinitis, and so that's getting at that. Oftentimes people with vasomotor rhinitis do have perennial symptoms, but often it is worse with season changes, and so it can be very confusing, and when you're trying to determine if it's allergic or not.
Yeah.
Yeah.
Okay. So the big buckets of this are sort of allergic or non-allergic rhinitis.
Yeah.
And then when you say perennial rhinitis, I mean, I don't know that and I'm not sure, Paul, if you felt the same way. I've just like okay, it's seasonal allergies, it's rhinitis, and I don't really perennial versus is it just,
Yeah.
seasonal or allergic rhinitis. That wasn't a distinction I had really thought that much about before reading for this. And I see in the literature, they do make the difference. Clinically, do you think, Jumi, how important do you find that to be?
Yeah, it's very important. I mean, I'll first of all say that one pet peeve I have, and our trainees do this as well, like especially in the beginning, is anybody with rhinitis, they'll call it allergies or seasonal allergies. A, it may not be seasonal, and B, it may not be allergies. And so I always, the correct terminology is simply rhinitis, and you have yet to determine the rest of it. But yes, it is important. And, I think one thing to keep in mind is people always assume testing will give you all the answers, right? Hey, give me a skin test and tell me what I'm allergic to. But sometimes it's not revealing. And really, we're back to the clinical history.
That is helpful. Paul, I have been guilty. I'm going to admit it to the audience right here. I've been guilty of saying, seasonal allergic rhinitis or allergic rhinitis instead of just calling it rhinitis before I really know what it is, for sure.
Chronic rhinitis. You can call it chronic rhinitis. Yeah.
Okay.
Mm-hmm.
I have had to try to talk people into vasomotor rhinitis because I think it's such an interesting entity, and I have less success than I would like to. But other than that, I'm probably guilty of the same sins.
I think we'll end up talking about vasomotor rhinitis quite a bit because it's harder. It can be hard to treat, but there are things you can do.
Okay. So what would your first office visit look like for this patient? If we referred them, your primary care doctor refers them and says, this person has seasonal allergies. What would you do for them? I think part of it is maybe challenge the diagnosis.
Well, yeah, I would just get more information. This patient you presented as atopic. And so, and again, the nature of the symptoms, the seasonality, all of that, I'm going to pretty much predict you'll have allergies. And so after I get a good history, of course, I'll take a good physical exam. And that, in an allergy office, we do the lung and heart exam. And we also will do an oral and a nasal exam as well, which many people don't get to do. Many patients don't get until they get to an allergist's office or an ENT. And when we do the oral exam, we're looking for evidence of throat drainage, postnasal drip, cobblestoning in the back of the throat, for example. And then when we look in the nose, is it inflamed? Are the turbinates inflamed? Are they pale and edematous like you might see with allergic rhinitis, or are they not? Like you might see with non-allergic rhinitis, or are there surprises in there like polyps and other things? And then we, in this case, will certainly do allergy testing, which I can describe if you'd like now. But typically before we do allergy testing, I really counsel the patient about how we are to interpret those results. And so we test the things that will include a cat, like I'm seeing here, and dog. And we essentially test to those two pets because they're pretty obviously ubiquitous, even if the patient themselves don't own one. We test for dust mites and molds and of course pollens. So tree pollens, there's several of those, weed pollens and grass pollens. Uh, depending on which allergy clinic you go to, there may be an expanded panel. So when in our office, we also test for mouse and cockroach because of course we live, or in my case, I live in Philadelphia, and those are prevalent in the city. And then, and that entails essentially pricking the skin. It's a percutaneous prick with extracts of the allergen. These are pre-made by the companies that make them, and that are stored in the fridge. And so we essentially prick the forearm with this liquid extract on the arm with a little pricking device, and we go away and we then come back 15 minutes later and see the results. And somebody who has allergies, this is somebody who has in their system excess amounts of that allergen specific IgE. That prick will result in a wheal, that is an elevated area that is itchy, and usually with a surrounding erythema. And the nurse does this testing. They then measure the wheal, and we consider the test positive for each particular thing if the wheal is a certain size, 3 millimeters greater than negative control. We always tell patients before they come into our clinic that they've got to stop their antihistamines for 5 days, because if they don't, they will not get a reliable test result. So our testing, the prick testing, always includes a negative and a positive histamine control. And so if somebody did not respond to histamine, we consider that test invalid. And similarly, if the person reacts to saline, which is the negative control, we also consider that test invalid because it may it suggests the dermatographic, for example, in which case everything can come up positive.
That's cool. That's very,
super cool.
it's simple, but very, it makes a lot of sense.
It works. And so once we sort of see the results there, and we discuss it with the patient, and really the assessment, the planning, the counseling, it's based on the test results, obviously based on the clinical history. It involves discussing the positives and the negatives, and as whatever the case may be. And if there are positives on the allergy testing, we of course talk about avoidance measures, right? And we can talk about that at any point if you'd like, the various avoidance measures for the common allergens. And then we talk about therapy, medication, because it is usually impossible to fully avoid one's allergen, with the exception of pets. When you get rid of the pets, the patients rarely get rid of their pets, and I don't, in fact, usually ask them to, unless it's causing really bad asthma symptoms or something like that. So
Paul's allergic to cats. He just takes 100 milligrams of prednisone a day.
I was able to get a patient off of omalizumab because they got rid of Peaches, the cat.
Yeah.
So every so often, I felt terrible, but like it was.
Does Peaches live with you now, Paul? Because I know
I would not.
I'll take care of him. Yeah.
Can we, before we get into the specific sort of treatments and a little bit more on the evaluation, can you talk us through the pathophysiology a little bit, as much as the internist would need to know? I know with immunology can get hideously complicated, but just in terms of sort of at an internist level, and then maybe sort of what you would tell the patient, can you just sort of talk us through what's happening when we're dealing with allergies?
I think that's a great idea, and I'll try to do it simply and without pen and paper. So just at the fundamental level, how does an allergy develop, and what's happening when somebody's having an allergic reaction? So I'll take birch tree pollen. And so these are the players with allergies. Many of you will recognize them. There's IgE, there are mast cells, there's histamine and other mediators. So when somebody who is susceptible, right, genetically usually susceptible, or we don't know what makes one person susceptible and the other not, but in a susceptible individual, they'll be exposed to birch tree pollen for many, many spring seasons, repeatedly exposed, right? And then at some point, they start making excess amounts of IgE, which is an allergy sort of antibody that is specific to the birch pollen. And that IgE, once it's being made and it's made in excess amounts, it binds to its receptors on the surface of mast cells. We all make mast cells. They're made in the bone marrow. They travel and they live in the skin, in our lower respiratory tract, in our GI tract. That's important because that's how symptoms occur. And so when somebody is sensitized, that means that that birch-specific IgE is now bound to its receptors on the mast cells. Now they're sensitized. And then at some point, we don't know when, what determines the threshold, they're exposed to birch tree pollen again, and now they are symptomatic. And what's happening in those situations is that that birch tree pollen, when they're exposed, is enough of that allergen antigen binds to its antibody, and that causes the receptors on the surface of those cells, those mast cells, to cross-link and degranulate. So you have a release of mast cell mediators. Histamine is the one we are all very familiar with, but it's important to remember that there are other mediators because we target them as well with our therapies. Leukotrienes are released, prostaglandins are released, cytokines are released. And so the symptoms that you see with allergies and with asthma are mediated by those things, those mediators from the mast cell. That's a simple version.
I followed all of that. That was a great
Yeah, that was
explanation.
great.
Yeah.
Paul, I feel like a doctor again. I'm learning, I feel like I'm learning, you can still learn stuff, Paul. It's good. So explaining this to a patient. So it sounds like you're pretty confident. And how much of this do you explain to a patient when you're trying to talk to them about seasonal allergies and what that should mean to them?
Yeah, it's a good question. So I don't usually explain all of that to them, but what I do end up explaining to them when they don't have allergies, because people are completely confused when they know they have seasonal symptoms and they know that allergy test has got to be positive and it's not. And typically what I will explain to them is, yes, you have rhinitis, but it is not being mediated by IgE to these things, and it's not histamine mediated. And I try to sort of explaining it so that they understand why I'm not treating with antihistamines, why they cannot get allergen immunotherapy, that type of thing.
I love how you answered my question, which wasn't great, with a very much more interesting thread. And now we get to
Master
talk about
educator.
these non-allergic
Yes,
rhinitis, because I do feel like probably a lot of us are missing non-allergic rhinitis or just assuming everything is allergic. So can you talk a little bit about non-allergic rhinitis and maybe what causes that and how you explain that to patients?
Sure. And I think it's particularly important for the adult population. So up to 30 to 40% of patients with rhinitis have a non-allergic rhinitis, right? So that's not an insignificant portion, especially if the onset is in later adulthood. That's important. Now, somebody who's had allergies all their life can, of course, present in their 50s still with allergies, but somebody who's had allergies for their first time in their 40s, 50s, 60s, my antenna is up. So first of all, what is a non-allergic rhinitis? It is, as the name suggests, rhinitis that's not mediated by environmental allergies. And it is a diagnosis of exclusion. So you need to have tested, of course, for allergies in these patients. And the most common form of non-allergic rhinitis is vasomotor rhinitis. I'll talk about vasomotor rhinitis shortly because that's what we typically will see, but there's sort of medication-induced rhinitis, which I have to be honest, even as an allergist, I don't think about that much, but I have had patients who have really weirdly acute onset rhinitis in whom I will suspect it. And I'll just spend this little bit of time just reminding people about the drugs that can cause them. Because as internists, we prescribe them all the time. And so they include antihypertensives, birth control, estrogen, progesterones, erectile dysfunction medications.
Oh,
And
interesting.
so when I've had patients, the few that I've diagnosed with that, and I wouldn't be surprised if I've missed some, is when there's this like just really acute onset in an older gentleman. I'm like, hey, did you start anything before this came on? And you'll identify it that way.
It sounds like these things cause like vasodilation. Like, I wonder, these patients typically have like mild underlying disease, then it kind of clears itself when they start the medications, or is this happen sort of de novo?
Often happens de novo. When it's not de novo, it's going to be harder to suss out,
Yeah, I
right?
guess that's right. Sure.
But I do think it has to do with the vasoactive properties of these drugs. And so, those people won't have itching, they won't have sneezing, they won't have any of those histamine-mediated type of symptoms. They'll have maybe congestion and they'll have rhinorrhea. Those are the kinds of symptoms that they'll have. Anyway, so that aside, vasomotor rhinitis is a form of rhinitis that really has to do with this imbalance in the parasympathetic and sympathetic input to the nose and sinuses. That's probably the simplest way I can put it. And it's sort of like a vascular neurologic issue, very similar. And I often will explain it to patients like migraine of the sinuses. And a lot of people can relate to migraines, right? Migraines are essentially a vascular neurologic sort of, pathophysiology type of thing. And it's interesting because some of the things that trigger vasomotor rhinitis also will trigger migraines. And so vasomotor rhinitis, typically the symptoms that predominate are things like congestion, nasal congestion, and drainage. Postnasal drip can be really prominent. Some patients have a very clear postnasal drip type of phenotype, you could say. Some people have a more of a sinus pressure and nasal congestion phenotype. But either way, they usually don't have ocular itching or ocular symptoms. Again, they don't have sneezing, they don't have itching. Now, we in terms of pattern, it is often year round. Okay. But then there are things that are going to make it worse. So things, as I mentioned earlier in our conversation, like temperature change in the atmosphere, changes in the barometric pressure in the atmosphere. So, rains is up, it rains, the pressure falls, things like that. So spring season is often a time that's really difficult for people. And sometimes dry air will make it worse, and humidifiers are amazing for this, by the way. And strong fragrances, fumes. These are questions, and when you ask that, you'll be amazed at how many patients will nod their head and be like, "Yeah, totally, that's me." Anyway, so those are the features, I guess, of vasomotor rhinitis. And I should add that there's mixed rhinitis where somebody does have vasomotor rhinitis and they have allergic rhinitis. And they may have vasomotor rhinitis year round and they may have allergic rhinitis seasonal. It's good to identify those patients as well.
Paul, you ever get this guy? It's usually a guy that just like every time they
It's
take a
always a
bite of
guy.
food, like their nose runs.
Oh,
Yeah.
Do you guys, yeah.
So what is that one?
That's another form of non-allergic rhinitis called gustatory rhinitis. Gustatory, that means taste, right? And so that's also weird. It's probably weird nerve autonomic problem, right? And yeah, gustatory rhinitis, very, very clear type of history like that.
Yeah. Okay. I definitely see that one. I
Yeah.
guess we should talk about treatment at some point. Paul, are we at that point, or is there other things you want to get to? I always jump the gun.
No, yeah, we're far down the path. So let's cut it back to Clara. So you'll recall is our patient with atopy, and we're solidly in what feels at least like allergic rhinitis territory. Am I allowed to call it that?
Yeah, let's call
Okay,
it
great.
allergic rhinitis.
So
I don't hate allergic rhinitis, no.
Okay. All right. Just checking in. So for her, I mean, let's assume that I'm her primary care doctor and so I'm incompetent and have not done anything right. So what is a great place to sort of start with? What are our foundations? And then how would you expound from there?
Yeah, so she's not really doing what she should be doing from what the story that you gave me. Benadryl is short acting and it's sedating, so no good. So we would, in terms of therapy, after we've talked about avoidance measures, and we give them information all about this. If they have a cat and they don't want to get rid of the cat, don't let it sleep in your room. Vacuum frequently, get a HEPA filter. Use vacuum cleaners that have an embedded HEPA filter that is a high efficiency. It removes the particulate stuff that you can't really see, including dander and pollen. All of that stuff. There's more to that, but that's some of the highlights, and dust mite covers if you have dust mite allergies. And then in terms of treatment, virtually everybody who's coming to me with rhinitis will be prescribed, or I will recommend a nasal corticosteroid therapy. That is first line for really all forms of rhinitis, at least allergic and non-allergic rhinitis, maybe not gustatory rhinitis. And if you have to choose just one therapy, usually you need more, but you have to choose one, nasal corticosteroids are actually more effective than oral antihistamines. It is very much underutilized by, I think, certainly by patients and sometimes by physicians. And so we'll start with that. And they're different in many of them. And over the years, over the past decade and a half, virtually every allergy medicine is now over the counter. So one by one, they've all come over the counter. And so there are several to choose from, and I don't necessarily endorse one over the other, but depending on patient-specific factors, I might. That's number one. The patient, like Clara, would probably need an oral antihistamine as well. And typically you'd give a second-generation antihistamine, which are usually non-sedating, right, and longer acting than diphenhydramine. So you have loratadine, which is the least potent of them. That's Claritin, the more common name. Cetirizine, which is Zyrtec, and fexofenadine, which is Allegra. And not to forget levocetirizine, which is Xyzal. So we'll start one of those usually as well. So probably at the least, Clara was going to earn herself those 2 therapies at the first visit. That helps with a lot of people. And let me add one thing. If she has ocular symptoms, so allergic conjunctivitis, you want to give her, because a lot of people don't get this, an ocular antihistamine that she can use as needed as well. We find that actually ocular antihistamines are more effective than oral antihistamines, again, if you're choosing one versus the other. And when you're giving these therapies, good to show them how to use it properly, because nasal steroids don't really work if they're not used with the correct techniques. And so, the first thing you tell them is, look, this is a preventative therapy. It is not to make you feel great after you've started having terrible symptoms. And so I feel bad today. Let me use my nasal steroid spray and it's not working. Well, it's supposed to be used preventatively. And it's a corticosteroid. It's anti-inflammatory. It takes time. And so it's 2 sprays each nostril once a day, or 1 spray twice a day, whatever it is. And the technique is important, and I'm happy to show it since we're on video. So what we tell patients is to bend down, slightly, like I am, and you put the nozzle in your nose. And as you spray, you don't spray right up through your nose, which is what most people will do intuitively. You actually spray it at an angle, so laterally. So an ipsilateral, so left nostril towards the direction of the outer part of the left eye. You'll spray, you'll take a light sniff, you'll spray again if you're doing 2 sprays, and take a light sniff, like a smelling a flower, and the same thing on the other side. And we kind of say you want as little of it to go down your throat. That is not the intention or intent. And if, people say, oh, but I have postnasal drip. Well, your postnasal drip is coming from your sinuses. And so you're trying to get it into your sinuses. And that's really with any nasal spray. And again, daily, regular use.
Yeah. I feel like the impulse is most people are like Scarface Paul. They're just like snorting as hard as they can.
Yeah.
And probably most of the medicine is just like bypassing the area where you want to get it to.
Yeah. You taste it, you waste it is what.
Yes. While we're on the topic, I mean, you alluded to you don't endorse one intranasal inhaled corticosteroid over another, but it sounds like there are some patient factors that might sway you towards one versus the other. I mean, since they're all available over the counter, can you just talk through the specific step a little bit?
Take the cheapest one.
Great.
Yeah. Well, that's what I would do. That's what I do. And but by the way, I should add that, I mean, sometimes insurance will cover it. And so I usually will try to send it in just in case it's covered. So a few things. Fluticasone, which is probably the most commonly prescribed one, or commonly known one, also known as Flonase, has a flowery smell/taste, very strong one. And some people just can't stand it. And so they don't get fluticasone. You give them maybe nasal mometasone or Nasonex or nasal triamcinolone or Nasacort. So that type of thing. Sometimes one didn't work and I tried the other. That's rarely that's the case. Usually by the time I use correct technique, that's enough. And if one doesn't work, usually I'm adding something else. But once in a while, I'll do a little switch and see if that makes a difference. I'm trying to think if there are others. I think that would be the main thing. I should add one more thing. I'm sorry, because this is not talked about very often. There are sort of what we call first generation and second generation corticosteroids. And so some have lower bioavailability. First of all, corticosteroids nasal ones are safe and they have very low or negligible sort of systemic effects. But if somebody's concerned about that, or somebody, for whatever reason, does have what seems to be systemic sort of effects, which is exceedingly rare, but let's say there's a concern about that, you might do a second generation corticosteroid that has lower bioavailability. So mometasone, fluticasone, for example. So that's just one rare example.
Yeah, I did go down a little bit of a rabbit hole trying to look this up. It looks like they've looked at, does this mess with diabetes? Does this mess with the HPA axis? Does it cause osteoporosis and things like that? And it didn't seem like there was really signal for that, which is reassuring.
Which is very.
I mean, I have lots of patients that are using this like pretty frequently, and they have been on it for many years. So
super important, right? Because sometimes it's lifelong, and patients worry about this sometimes because a lot of, when you look at the labels of any corticosteroid, nasal and inhaled, they'll often talk about the side effects that you see with, especially inhaled corticosteroids, the side effects you see with systemic corticosteroids. And so patients are freaking out.
Yeah.
And one thing, glaucoma and cataracts There has sort of been some signal for higher risk of that, but that's also thought to be low. And if you have your typical patient who doesn't have that issue, even ophthalmology doesn't really make a fuss. And so I usually don't worry too much about that. Main thing is like nasal irritation, maybe nasal bleed, things like that.
Okay, so for the intranasal steroids, kind of prescribe what we think the patient's going to be able to afford. We can try to send it through a prescription, but most of them are available over the counter now.
Yeah.
You mentioned loratadine is a less potent, and that's been my experience having taken that medicine before. I find cetirizine for me to be very sedating, but I don't know if you differentiate like fexofenadine or desloratadine. Anything else you wanted to mention about those?
So desloratadine is another one, Clarinex. It's not very common. So cetirizine is sort of has had historically been marketed as non-sedating, right? Along with fexofenadine and all of that. But it can be. So 10-20% of people do find it to be sedating. And so I do tell patients about that possibility. Fexofenadine is rarely sedating, very rarely sedating. It also has the least anticholinergic effect of the antihistamines. And so that's usually pretty safe if you have an issue. And the interesting thing is every patient is different. So for some patients, once in a while, I'll find that loratadine is the most effective for that patient. That always is possible. And sometimes some patients do not respond to fexofenadine and all they respond to is cetirizine. Okay, well, take it at night, maybe even take 2 at night, which you can do, by the way. Doubling up your antihistamines sometimes at night will be helpful.
Oh, wow. So for any of the antihistamines, patients can potentially double them up. I know there's sometimes some renal dosing that pops up on them. I don't know that sometimes I think it says like 5 milligrams of loratadine. And even if I've told that to patients, like they don't believe me. And
they're taking 10 and they're good. They're fine. They're not like zombies. Yeah. So just a little sidebar for a different condition, chronic spontaneous urticaria, we go up to four tablets of antihistamines per day. And so it is fine. For rhinitis, I will often go up to 2 a day, especially during the peak season. And they're like, but it says 24 hours. It's okay. You can do either 2 at once or 1 twice a day.
Okay. Well, that is good to know, Paul. That's a good one to have in the back pocket. And so we talked about the intranasal corticosteroids. We talked about the second generation antihistamines, which are longer acting. We can double up on them if patients need to. And what about the topical antihistamine? So azolastine is one that I had always given by prescription. I know now you're seeing ads for it on TV. There's an over-the-counter product available. Are there any other intranasal antihistamines? And how do those compare to the other agents we're talking about as far as efficacy?
Yeah. Right. So that would be the next thing. So for this patient and many others, after you've tried the nasal corticosteroid. So nasal antihistamine, azolastine is one, and then olopatadine is the other. Okay. And yes, azolastine is the one that's now over the counter. It is a great addition. And it has sort of, in addition to its antihistamine properties, it has these sort of interesting anti-inflammatory properties, anti-kinin, different things. And so it's actually useful for both allergic rhinitis and, interestingly and surprisingly, for non-allergic rhinitis as well. So that's nasal. So, and you can prescribe both. Oftentimes you will prescribe both nasal corticosteroid and the nasal antihistamine. And there is a nasal spray that has both together and is called azolastine fluticasone or Dimista. And so if insurance covers it, I love prescribing that because they just like take it both at once and they're good.
I have never successfully gotten it covered.
We have the same.
Yeah, it's my patients are generally like, I could either do that or have a car payment. Like it's one or the other. So like usually I end up prescribing them individually just because I don't.
Yeah, because it's never covered. I don't know if you tried it recently, Paul, but I gave up prescribing it too. But lately in the past year, I've been prescribing it and it's like, I would say 6 out of 10 times it's covered.
Oh, all right.
I don't know what's happened. That can change again, of course, because the way these things go. But yeah, and I've been really pleased. And when it's nice that.
But they're so busy denying asthma medications, they forgot to block these probably.
Exactly.
I guess if I'm ever going to ask anybody this, it's got to be you. So this cromolyn medicine that is available over the counter, it's a intranasal mast cell stabilizer. And I believe it's an older medication that's been
Yeah.
around. And
Oh, yeah.
I think even it's been studied in the common cold. Is that something that we should put in our armamentarium?
So I think it can be there, but it's pretty specific type of uses. So cromolyn is, as you said, a mast cell stabilizer, and I find it to be useful in sort of specific situations. It is short acting, first of all. It is fast and short acting. And so it's typically a couple of sprays up to 4 times a day as needed. And so typically you'll use it, or in my clinic, I'll prescribe it when a patient has rhinitis that's triggered by specific factors. They anticipate they're going to visit a friend with a cat or whatever, and then they can use their nasal cromolyn 30 minutes before, and then and they can be helpful.
Okay.
I know this is turned into an interrogation, but that's okay. This must be your day to day, actually, this type of year. But I was going to ask, in terms of the Montelukast, which I have to assume we're getting to, is I feel like I see that used almost as a Hail Mary pass, and not for, like, maybe if someone has comorbid asthma symptoms, that might be a reason to pull the trigger on it. But for someone who does not have concomitant asthma, but does have significant allergic rhinitis or seasonal allergies, when might you pull the trigger on that?
Oh, yeah. I'm glad you asked that question. It's interesting. So I don't give Montelukast for allergic rhinitis without asthma. It's for the most part, my patients who have allergic asthma who I'll put it on for. At least not on top of antihistamines, right? So if antihistamines and all that aren't working, I rarely see it work. Having said that, I can think of a couple of patients for whom the Montelukast is really helpful. It was put on, like, in their regimen by another doctor, and I just haven't been able to take it off. And I'm like, okay, you're that person. And so I think it's like a minority of patients for whom it may be particularly helpful, that maybe they have a leukotriene predominant sort of rhinitis, perhaps. Interestingly, nasal congestion is pretty leukotriene driven. Who knows if we should be giving it to those kinds of patients? That level of specificity hasn't been studied. So just to be brief, it's not, certainly not first or second or even third line for patients who only has allergic rhinitis usually.
Okay, great. I feel better about that, because also my patients are reading the black box warnings these days, and are especially
that too.
About the
Thank you for bringing that up. And that's another reason why you wouldn't give it to somebody who doesn't have asthma as a comorbidity. Yeah.
What's the black box warning on that one, Paul? I never prescribe it. I don't even know what it is. Is it?
I believe there's neuropsychiatric side effects for the ones that they just put the black box on for.
Exactly. Depression, anxiety, suicidality.
Yikes. Okay.
For not probably helping with nasal drip. It just doesn't seem like it's worth it. It just might not be worth the squeeze.
Yeah.
Okay. So let's get back to Clara here. Let's say we put her on loratadine and fluticasone, and she comes back a month later. She's been keeping her windows closed. She bought a HEPA filter, and her symptoms are better, but she still wishes that, her seasonal allergies and brain fog that she experiences will improve. If she had actually been seeing Paul first and he put her on those, and then she's coming to see you, at some point, I think we talked about it up front, probably she would get skin testing if she's coming to see you. Yeah. And, like, who are you thinking about allergy shots for? Is that still a thing? Because I used to hear about that all the time.
Oh, is it still a thing? Yes. So absolutely. So I think she'd be a good candidate. These are the sort of the general criteria. Actually, if somebody has allergies and they want it, that's one criteria. And actually, you don't make a fuss too much if somebody wants it, even if they haven't tried the other therapies. But for me, usually, in order for it to be worth the time, the commitment, and the risk of allergic reaction, typically is you have not responded well to medical therapy. So you've tried the nasal corticosteroid, you've tried the oral antihistamine, you've tried nasal antihistamine and avoidance measures, and it's just an ocular antihistamine, you're still having symptoms. Yes, allergy shots are a fantastic option. I tell people about the process, and it's a way of desensitizing you and building your immune tolerance to these allergens. It takes time. And there are different protocols for allergy shots or allergen immunotherapy. But generally what it entails is injections, underneath, subcutaneous injections of extracts of what the person has been found to be allergic to. You inject these extracts, you start at a very low dose, very dilute dose, and you have the patient come in intervals, weekly, twice a week, for example, each time increasing the dose in small increments. And in our practice, our protocol, sort of that up dosing, up titration takes 7 months to get through. And when you get to the maintenance dose, which is what we call it, which is the full concentrate, then it becomes monthly. So much, much easier. And then the full duration of therapy is 3 to 5 years. And so, you don't get a benefit right away. Usually when you're getting to maintenance, that 7, 8, 9 month period, you're like, oh yeah, I can feel this. And so if I started shots this spring, it's not going to help you. It's going to help you for example, maybe fall, but certainly next spring. It's very effective for pollen, pretty effective for perennial allergens like cat, dog, dust mites. But because perennial allergens are perennial and they're right in your face, it may not be quite as effective, but it should make a big difference to your symptoms. And I always kind of make it when somebody tells me, how am I going to do with the cat if I get the cat? And I'm like, well, you'll be able to tolerate the cat. You won't be miserable when you visit cats, but you can't like sleep with the cat on your face, for example. So
I should be writing this down probably.
yeah. So that's the thing. There are different protocols, and like in certain clinics, they'll do rush protocol where that whole up titration takes days. It's just higher risk of allergic reactions, which by the way is the potential risk we talk about. So it can be anywhere from a local allergic reaction to anaphylaxis. And so that is a present and real sort of risk. And so in our clinic, we always have somebody on call in case anaphylaxis does occur, which is why it has to be done in a clinical setting with monitoring after each shot.
That's a quite a commitment. I mean,
it's intense.
Wow, that's a lot. I didn't realize it has to go on for up to 5 years.
It is.
And does insurance cover that? Like by the time someone's getting to you and that's indicated and they've tried everything?
Virtually universally, I have yet to prescribe shots for somebody for whom it wasn't covered or for whom it was cost prohibitive. I mean, maybe it's possible, and I just haven't had that experience.
Oh, that's great. That's great to hear.
People sometimes talk, and I just want to mention this because people may wonder. Patients talk about this. They'll come in and say, hey, I want the one that you put in your mouth, not the shots, the one that you put under your tongue. And the sublingual immunotherapy does exist for certain allergens in the United States, not every allergen. And so it only exists for grass and dust mites and ragweed. And so if you have a bunch of tree pollen and pet allergies, forget about it. It's just not going to work for you. But the benefit of it, if you do have one of those, is that you can do it at home. You take it every day and it's much easier.
Yeah, the grass one doesn't upset me so much. The idea of doing a sublingual dust mite allergen really just kind of skews me out. I have to be honest. It just sounds deeply unpleasant.
Yeah, your vision.
Not so much.
Okay.
Yeah.
Well, let's say that Clara, she comes to you for allergy testing. You become best friends over the next 5 years, and she does great. Would Clara typically have to continue her fluticasone or the loratadine even when she takes the allergy test, or at the end of that, might she just be off all meds?
Oh yeah, it varies patient to patient. So ideally, you want to be in a situation, at the very least, where when you're taking those meds, your symptoms are totally controlled. Many times patients can reduce their meds though. So not taking double antihistamine, not taking 3 nasal sprays, maybe taking 1 or 2. It really varies from patient to patient. The other thing is the dose of what you're putting in. So we literally create these, I call them potions. Like, the allergist decides how much of each thing to put. There's a therapeutic range, and like depends on where you do it. It's sort of an art, and so there's a variability in terms of how well. So I kind of tell people you should be much better, but you may not be all the way better. So
This sounds kind of fun, Paul. I think we went into the wrong field.
It's so much fun. Yeah,
she's mixing potions.
That's it. Primary care is my jam. You know this, man.
I know. You're America's primary care physician, Paul. Okay, so let's move to a different case. And let's say, Paul, this is one of my guys with the non-allergic rhinitis. And we know that because we sent him to you for allergy testing. We thought he had allergic rhinitis, but he didn't. And so we knew he had some sort of non-allergic rhinitis, vasomotor rhinitis probably. But he also has that gustatory rhinitis. What can we give him for that? Like what works well? And ipratropium is something I've seen thrown around, but I'm not sure. Is that okay to give that, or are we just wasting our time?
Well, so this guy, I will assume you've already started with a nasal corticosteroid because that's still something you want to start with, and a nasal antihistamine because, as I mentioned, it is also good for non-allergic rhinitis. So I would do those.
Mhm.
If he's still symptomatic, I will try nasal ipratropium. Ipratropium is an anticholinergic therapy, and it's particularly good in rhinorrhea predominant rhinitis because it
Mhm.
reduces drainage. That's what anticholinergics do, and so it is pretty short acting. You can use up to 3-4 times, usually 3 times a day, and it can help reduce the drainage in somebody who has non-allergic or vasomotor rhinitis. In this patient, I would definitely consider saline rinses or saline irrigation as well. This is something that's oftentimes is forgotten, but sometimes you can, and I would insert the saline irrigation perhaps even before all of this, the ipratropium and all those things. It can be quite good for people with, again, drainage, a lot of drainage. It can be good for people with congestion, people with sinus pressure. It can be good for a lot of people. And basically, that's something you purchase. You can make it yourself, but don't use table salt. But you can purchase this. The most common brand is Neilmed, and Neilmed, not endorsing them specifically. But it comes with salt packets, distilled water. Put it in there, 8 ounces of this solution. Microwave it for 15 seconds, and you irrigate your sinuses, and that can be really helpful as well.
Yeah, I will confess, I have used a lot of the neti pot over the past year,
Yeah,
and I do find it is really helpful. And
yeah, yeah,
I've been recommending it to patients for years. I had used it years ago, but I've been much more consistent, and it
yeah,
does it. I think it works really well.
yeah.
And the warm solution definitely makes it a lot easier.
Much more pleasant, right?
Yeah.
And so don't forget to tell them that step. And a lot of people are just have an aversion to doing something like that. They
Mhm.
think it's going to make them drown or whatever. And so there's a little bit of dispelling of those things. And once they do it and it helps them, they're hooked. And so it's sort of getting them to let them. You'll get used to it. Just give it a try.
Mhm.
I think we talked about this in a prior episode, but there's a YouTube video. Is it Dr. Adapa who actually demonstrates high volume
Okay, yeah,
sealing on himself? It does
yeah,
a very like it looks not nearly as
nice,
terrifying as it sounds. And I show that to patients all the time and
yeah.
give them that YouTube link. And it's
I have a dot phrase that puts that into my notes
Oh,
yeah,
to
great.
send it to people. Yeah.
because when they buy into it, when they finally try it, they're like begrudgingly like, okay, yes, it actually did help. But just getting
Yeah,
them sort of over that initial hurdle, the idea of spraying lots of stuff up their nose, but it really is
Yeah.
kind of miraculous.
yeah, for sure.
One tip too that I've heard is tell them to use it in the shower because
Yes.
they're already having water drip from their face, so it just feels less weird.
Yeah, that's really great advice. Yes. Yep, over their kitchen sink or yeah, better yet in the shower. Yeah.
Okay.
And they can use it as needed or every day, depends on the
Yeah.
situation. It can also help reduce sinus infections. We didn't talk about that, but a lot of these patients get recurrent sinus infections, and doing these things will help reduce the incidence of that as well.
Hmm.
And
Yeah.
then lastly, I'll throw in here that it can be really tough treating patients with vasomotor rhinitis, especially older patients. It can be refractory, and so I can talk about all these therapies, but sometimes it's just it can be notoriously hard to treat, especially when they have a lot of postnasal drip as a component, and that's just you know. A known fact, and so sort of talking to patients about that can be maybe helpful in setting their expectation.
For either this vasomotor rhinitis or the allergic rhinitis, like we talked about in the last case, are there ever times you're hitting people with systemic steroids for that?
Yeah, so typically if I'm using corticosteroids, systemic corticosteroids, it's when they have allergic component that's just really bad. And I'll use a short course of steroids. Yeah. I rarely do it, but yeah, I have done it.
Mhm.
A patient is just just has profuse symptoms. They're waking up with their eyelids shut because they have horrible allergic conjunctivitis. They can't breathe through their nose. Then you might do a course of steroids in those patients and then try to get them through.
Mhm.
And then I think the other situation where I do that is if somebody has severe turbinate inflammation on exam, none of those therapies I recommended will really help that much potentially. Well, it depends. Sometimes it won't help that much because it's just not getting through. It's not
Mhm.
doing its thing. And so I will sometimes give a short course, like a 3-day course of prednisone, and then they can go on and then get on that therapy and sustain the benefit.
Mm.
So there's a little trick I use sometimes.
Paul, any other questions? We're moving towards the end here.
I just want to say out loud, and probably I'm sure all our listeners know this already, but I noticed during our discussion of nasal sprays, at no point do we mention oxymetazoline, which is which I've seen actually enough rhinitis medicamentosa, which I love saying out loud, but I've actually
Yeah.
diagnosed a couple of times.
Yeah.
Is that anything that you even recommend in the short term? Or is that just absolutely verboten for patients? Because I try to dissuade almost everybody.
Yeah. Like, as you said, it's like no, it's terrible for long-term use. Having said that, there are situations when I recommend it. Actually, the one that I just described, where someone has really, really severe congestion, you could tell them to use oxymetazoline, couple sprays, wait a few minutes, and then use their nasal spray. But that's only going to be a short period because, as you know, using it more than 3-5 days consecutively, you get rebound congestion or rhinitis medicamentosa. And yeah, the other situation I have people use oxymetazoline, also known as Afrin. Before I go on, oxymetazoline is not only known as Afrin, it's known as many other things. So there are many times when I've had patients come in and tell me they're using a nasal spray I haven't heard of, and I Google it and find out it's just another brand of oxymetazoline. So it's a really good idea to just double check what exactly it is they're putting in their nose. Anyway, I do.
It's wise advice in general.
Right, exactly. During the flight, like, so some people have like really bad sort of related to the altitude type of pressure-induced rhinitis symptoms and congestion. So that's a great time to use oxymetazoline before the flight, maybe even during. It's very short-acting flights, people who travel a lot.
Oh, wow. I would not have thought of that. That's great. That's another
Yeah.
great tip.
Yeah.
Yeah.
What about sinus? You're talking about enlarged turbinates. What about sinus surgery? Like when are you just deciding somebody needs a sinus surgery?
So luckily, I don't have to make the decision about sinus surgery myself. I send them to ENT when, or ears and throat doctor under certain circumstances. So sometimes if somebody has what sounds like sinusitis, chronic sinusitis. So their main symptoms, yes, they may have runny nose and stuffy nose and nasal congestion, but they have a lot of sinus pressure, sinus pain, sinus headaches. Those are really usually indicative of a sinusitis. And that's not responding because a lot of that responds to nasal steroids and it's not responding to medical therapy, then I'll refer them to ENT. Or if a patient clearly has something structural based on their symptoms, my symptoms are totally unilateral nasal congestion and it's worse when I lay down like this and that type of thing, then I'll also send them to ENT. Oftentimes, and then if I suspect nasal polyposis, and a good indication of nasal polyps, apart from nasal congestion, is hyposmia, so difficulty smelling, then I'll send them to ENT. And oftentimes I'll get a sinus CAT scan before I do that.
Mhm.
And that helps me feel good about my decision and also helps the ENT.
Yeah.
Then they can decide if they want to do surgery, and sometimes they do. Yeah.
And one tip we had from we did a chronic sinusitis episode a couple years ago, and the ENT doc said, make sure that they take some therapy and get the sinuses as good as you can, and then get the CT because if there's, I don't want to see their CT on no therapy because
Right.
I know that's going to look bad. I want to see how good you can get it looking. That helps me decide if I need to
Totally.
operate or not.
Yeah, that's a good way to put it, right? Because they themselves will often do all this medical therapy before they do sinus surgery if the allergist has not done it before then.
Okay, so Paul,
Yeah.
I mean, clearly we got to end with climate change, right?
I think we have to. Yeah, I was hoping we get to the big ticket questions. So the easiest one to fix, probably, Jimmy, is so. But I would like to ask, with climate change and its impact on the overall environment, increase in pollution, sort of all that stuff. I don't know how specifically you can speak to, but how has that impacted your overall practice and sort of the prevalence of sinus symptoms that we're seeing these days?
Right. So, I think many of us know or feel that allergies are just increasing, right? They have been for the past 5 decades. Allergic rhinitis, asthma, food allergy, all these things. There's many factors, but with allergic rhinitis and asthma, we do think that climate change is likely having an impact. And I do see it. Like, I see it in spring season. I like every spring, it seems, oh, this is the worst allergy season ever. Each spring, somebody is saying that. And, part of it is related to the fact that pollen season, I'll speak about pollen. Pollen season often starts earlier now and it lasts longer, right? So that obviously it can be problematic. Sometimes lasting longer, let's say tree pollen lasts longer. Tree pollen is usually in the spring. And if that lasts longer, it's bleeding into grass pollen. season, which is in the summer, June, July. And if you have both allergies and you have a bunch of both around, that can be problematic, right? There probably is something going on with the composition of the pollen as well that makes it more allergenic because of climate change. How pollen is transported or dispersed and all of that is affected by climate change. And so there's that. And then there's just more particulate matter, just pollution, right? Related. And so VOCs and there's all of these things in the wildfire. I mean, all of these things, although those mainly cause irritant issues, irritant rhinitis and irritant asthma. So yeah, I think we're seeing the effects very clearly in our clinical practice.
Probably more allergy shots will be needed, which is,
Yeah.
the good news is they work and they're covered by insurance, so we should be able to get them for people.
Yes, exactly. We will be employed as long as we want to.
Okay. Well, this has been fantastic. And Paul and I could keep, Paul, you called this an interrogation. So I'll say we could keep interrogating you. I like to think of it as an interview, but I guess it was a little bit of an interrogation.
A little bit of both, yeah.
But we would love some take-home points for the audience. Just a couple that you really want them to remember.
Okay, yeah. So, I guess the first thing is for the audience is the importance of the clinical history, probably, and remembering that there is such a thing as non-allergic rhinitis or mixed rhinitis, having both allergic and non-allergic rhinitis. And that might be helpful, perhaps, even if you're going to send them to an allergist, to let them know that so that they know that there are various possibilities.
Mm-hmm.
And then, I guess people often ask when to send to an allergist. I guess if you listen to this, you may not send them to an allergist as much. And I think that's okay. But I think you can send people to an allergist anytime. And certainly if somebody might need shots or want shots, you can send them to an allergist if somebody's not responding to your treatments. And then if somebody has comorbidities, and I would say the vast majority of allergic rhinitis have atopic comorbidities. And I think sometimes when they have multiple of them, allergic rhinitis and asthma and eczema and chronic urticaria, then I think that's a great time to send them to an allergist as well.
And lastly, anything that you would like to plug?
No plugs.
All right.
Not at this time.
Then we will let you get on with the rest of your night and we'll stop the interrogation formally, Paul. This was really fantastic. It was great having you on the show again, and thank you so much.
Yeah, you're so welcome.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Still hungry for more? Join our Patreon and get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value practice-changing knowledge. And to do that, we need your feedback. So please email us at askcurbsiders@gmail.com. Please subscribe, rate, and review the show on Spotify, YouTube, or Apple Podcasts. Reminder that this and most episodes are available for CME for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. A special thanks to our wonderful writer and producer for this episode, Dr. Leah Witt, and to our whole Curbsiders team. Our technical production is done by Podpaste. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Krista Chu-Man-Chu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.